Well, welcome. I think we're at the top of the hour. You have joined the US Deprescribing Research Network's webinar. We're super excited for today's webinar. Today's webinar is on Deprescribing and Delirium. And this is co-sponsored by the US Deprescribing Research Network and the Network for Investigation of Delirium, NIDUS. My name is Jennifer Chia. I'm an investigator at UMass Medical School, and I'm here with with Ken Bookfar, and we co-lead the Investigator Development Core at US Deprescribing Network, and we're going to be your hosts today. Before we get started, I want to cover a few technical issues. Due to the number of registrants for today's webinar, we have placed all phone lines and computer lines on mute to reduce the audio feedback. So unless you're logged in as a host or panelist, your line is going to be muted. However, we do welcome and encourage audience participation using the Q&A feature or the chat feature in the Zoom webinar software. If you'd like to interact with the presenter, please use the Q&A feature bubble at the bottom of the toolbar and type your questions in the box. If you would like your question to be anonymous, you can check anonymous box before sending. Hosts will acknowledge questions during the final 15 to 20 minutes of the webinar. After the webinar, you'll receive an email, and the email will include a short evaluation. If you have technical or logistical questions, and I see there might be some in the chat for some people here, we ask that you submit those in the chat box and select the co-host, Gabrielle Schiller, and chat privately. Please make sure that you are identified either by name or participant ID so that the webinar host will be able to troubleshoot any problems that you're having with audio or other issues. And I would just, as always, like to extend a huge thank you for all the people behind the scenes who make this possible, including Gabrielle Schiller from Mount Sinai, Jonathan Norton from Johns Hopkins, as well as Raha Shruti and Haley Schiff from UCSF, who just do an amazing job pulling off all these things to make this happen for all of you and for us. And without further ado, I would like to introduce Cynthia Boyd, one of our co-leaders, who will have some announcements and describe the Deprescribing Network for you.
Thank you so much. Thank you so much, Jen. I'm very happy to be here, and we're really excited about this co-hosted webinar. Could we advance to the next slide? I'll just tell you a little bit about the US Deprescribing Research Network. You can see our link to our website on the bottom of the slide. It's deprescribingresearch.org. If you go to our website, please click the Join the Network button. We send out emails just once a month, but we'd love to have all of you, particularly our colleagues from NIDUS who may be with us for the first time, join our network so that we can keep you updated about upcoming activities and events. And we only send out something about once a month that summarizes everything that's going on. We're really delighted to welcome everyone from NIDUS here today. We're excited about this presentation. Two of our most recent highlights are listed here on this slide. One of them is the Junior Investigator Intensive Program, which is led by Jen Chia and Ken Bookfar. And this is a series of activities that are really designed to build community and mentorship for junior investigators who are embarking on deprescribing research. And you can find the details on our website, and the deadline for that is February 1st. And it's not an onerous application. There's definitely still time. And we'd really welcome your checking it out. The second piece is our annual meeting, which this year is scheduled to be the day before the American Geriatric Society meeting on Wednesday, May 11th in Orlando, Florida. And you can register on the American Geriatric Society meeting page under pre-conferences. We'd love for you to attend both USDeN and American Geriatric Society meeting, and you register for both of them or one of them on that page. So I'm happy to turn it back over to you, Jen, for the next slide.
Thank you so much, Cynthia. And now it's my honor to introduce you to Dr. Sharon Inouye, who really needs no introduction. But Dr. Sharon Inouye is professor of medicine at Harvard Medical School and director of the Aging Brain Center at the Marcus Institute of Aging Research at Hebrew SeniorLife. She developed the Hospital Elder Life Program, HELP, to provide age-friendly care, and it's being implemented worldwide. She developed the CAM, and the most widely used delirium tool worldwide, and it's been translated into over 20 languages and cited over 20,000 times. She also serves as the associate editor of JAMA Network Open and is an elected member of the National Academy of Medicine, the AAP, and the ASCI. She's also served as a health and aging policy fellow and American Political Science Association Congressional Fellow from 2016 to 2017. Welcome, Sharon. Thank you so much for being here.
So excited to be here, and I really want to thank the USDeN Network for inviting us to co-host this webinar on a topic that's so near and dear to the hearts of both of our networks, delirium and deprescribing. I wanted to let those in the USDeN network know about NIDUS, because delirium, I know, is very often an important outcome for many of your studies and is an area just in general that's important for us to know about. So NIDUS is an NIH-funded network bringing together investigators interested in working on the topic across disciplines and across professions. We are in our renewal period now. We were recently renewed, and we're starting a new 5-year cycle. And during this cycle, our target is to really try to stimulate and catalyze collaborative studies. We have developed extensive resources available on our website, which is deliriumnetwork.org, to help you guide your research through choosing delirium measures, to harmonizing delirium measures, a variety of career development opportunities and funding opportunities that we hope will help to build delirium science. I wanted to bring to your awareness a few upcoming important events, such as our Delirium Boot Camp, which is an intensive training boot camp. Our applications for the next boot camp will open February 1st. They are due July 22nd. And the next boot camp will be November 13th to 15th in Chapel Hill, North Carolina. We're hoping it will be in person. It has been virtual the last 2 years. We also host junior faculty working groups. We will be announcing pilot grants very soon. If you'd like to find out about these, please register on the website. We also are very active with the American Delirium Society, which will have its meeting June 12th to 14th in Indianapolis. Please follow us. Here's our email if there's any questions. Next slide. And just very quickly to tell you the other leaders in our network, Dr. Rich Jones is the multi-PI with me, also heads our measurement core. Dr. Ed Marcantonio heads our research resources core, where we develop a biorepository of studies. It's not a repository, it's an indexed data bank of information in the studies. Our Dr. Michael Avidan heads our pilot core, and our career development and outreach core is headed by Drs. John Devlin and Jan Busby Whitehead. So thank you so much again, and delighted to be here, and turning it back over to you, Jennifer. Thank you.
Thank you so much, Dr. Inouye. And now, without further ado, let me introduce you to our speaker, Noll Campbell. Dr. Campbell is an assistant professor of pharmacy practice in the Purdue University College of Pharmacy and an investigator with the Indiana University Center for Aging Research at Regenstrief Institute. He is a clinically trained geriatric pharmacist whose research is focused on the impact of medications on the aging brain, including delirium and dementia. His research characterizes medications as potential risk factors for both poor brain health and and builds interventions to improve health, to improve brain health. So without further ado, Dr. Campbell, welcome.
Thank you so much, Jen. Good morning to some and good afternoon to others. It's kind of a rare part of the day that we get to do that. I want to first start with thanking you for the nice introduction, Jen, and both groups, both core leadership groups, for the invitation to present. I know many of the participants and attendees today because of my interactions with both of these groups in the past and networking, and I've benefited from both groups. So it's really a nice opportunity to be able to talk about these key important topics of both deprescribing and delirium with these groups. But I don't know everybody here today, and so by way of a bit of a further introduction, I just want to follow on that my research interests center largely around finding safe medicines to maintain healthy brains. And so today, along those lines, I'm going to share the story of our work here at IU, kind of intending to measure brain or cognitive outcomes through medication interventions. And so I want to focus on that point, though, that the goal of my interests and my research is really to improve outcomes. And you're going to hear that. We're going to talk today about some of the challenges with that and some of our lessons learned. And so I realize that this audience comes from kind of two fairly unique groups, but two groups that do have some intersection. And so the messages that I'm going to share are going to speak to both the delirium group as well as the deprescribing group at times. And I hope you'll see how our work is nicely nested in both of those interests. I have no conflicts to report, and a large part of what we'll talk about today was generated with support from the NIA, AHRQ, and HRSA. And so I'm going to lead with, first of all, give me any indicator if anybody has them that my slides aren't showing as intended. I made a little switcheroo before we got started, but I think we should be good now. So I'm going to begin with kind of highlighting the existing relationships between medications and delirium outcomes. So there's not a whole lot new here, but it's always worth starting, recognizing that the audience here is coming from a variety of backgrounds. We'll also cover or describe some of our prior trials, and I'm going to try to accomplish kind of navigating quickly through potentially 3 prior trials with deprescribing and delirium at their core, largely focused on the acute care setting for the first 2, and potentially expanding to the outpatient setting in some of our more recent work. And through that, I hope to identify some opportunities for deprescribing research for which you all could pursue or contribute or weigh in on if you're pursuing them currently. So no delirium and medication or delirium and pharmacology presentation is complete without scaring people first, right? I'll give a quick nod to a friend and colleague, Jose Maldonado, who put a lot of work in this figure several years ago, trying to understand what is the etiology of delirium. And it's heterogeneous, it's confusing, it's complex, and this slide appropriately depicts that. But it's also a way that we could use it to identify the multiple targets and etiologies that medications, or roles that medications can have in not only understanding what happens in delirium, but also potentially considering treatment targets. And all are of interest to us. We're going to spend a fair amount of time talking about both medications as risk factors for delirium, as well as medications as potential treatment targets. And so you can see on the slide, what I've done is overlaid where various types of neurotransmitter systems and medication effect could influence not only the incidence of delirium, but also maybe potential treatments for. And so these have all been significantly studied, but I think you'll hear that there are certainly opportunities remaining. So medications in delirium have been ever implicated in the etiology, but are seldom the exclusive solution or answer. And so you can see in the table, I've highlighted a variety of ways in which medications need to be considered as it relates to the onset of delirium. So delirium can occur when we're using prescription medicines, or even, as you can see, OTC medicines in the column on the left, when they're used as prescribed or used as intended for over-the-counter uses or symptoms. Sedative hypnotics, psychotropics, anticholinergics, so a variety of medicine, variety of classes that have potential confusional states, acute altered mental status, delirium, encephalopathies as potential side effects. And as we all know, recreational use can also result in delirium. Delirium can result from adverse clinical effects, such as hyperammonemia from valproic acid, serotonin syndromes that could be induced by, in part, antidepressants, as well as withdrawal states. So for those who might be attending that work in acute care settings, particularly emergency rooms, you might think of, when we think of, or at least pharmacists who are here, when we think of delirium, we really need to turn attention to a variety of medication causes, both use as prescribed clinical effects, as well as potential withdrawal states. And the withdrawal states are of particular interest, as you might know, to the deprescribing group. So while medications in predictive models for trying to identify or predict who might become delirious, medications are oftentimes represented as some of the strongest risk factors in hospitalized and critically ill older adults, as some of the strongest risk factors for delirium. However, medications alone are rarely or fairly seldomly the sole reversible cause. And so there's a lot to understand as it relates to medications and the etiology of delirium. So just as we think about medications oftentimes implicated as causes, they're also, so my last slide was ever implicated and now ever desired. They're also desired as a primary mode of treatment. But I also want to use this opportunity to reiterate that medication is not consistently appropriate as a treatment tool when we do find delirium. And there's some significant high quality work leading to those recommendations at this time that have been accomplished in the last couple of years, both from Lisa Burry as well as Karen Neufeld into nice reviews and recommendations against the routine use of either antipsychotics or pharmacological interventions in general when we do find interventions. Now, we are learning from a lot of the great work done out of the NIDUS network about potential areas where medications may be valuable. But at this point in time, routine use for the large majority of deliriums that might occur, responding to a new onset of delirium with a medication is not the ideal action. And instead, right now, because it's not recommended routinely to treat deliriums with a medication, the best pathway for us is to think about how can we deprescribe, either to prevent or to treat deliriums. And so with that, I'll move ahead into the next part of our objectives, and where we'll describe some of our prior experiences in deprescribing deliriogenic medications in the acute care setting. And so I'm going to stretch back a little bit to the first study I'm going to talk about, which began roughly in 2005, so almost 17 years ago, which was an intended study with a goal of evaluating the efficacy of a screening program, a cognitive screening program, and a computerized decision support system at reducing exposure to potentially inappropriate anticholinergics, urinary catheters, and physical restraints among hospitalized older adults who had cognitive impairment, defined as either presence of delirium, dementia, or MCI, mild cognitive impairment. And so the goal of this program was to try to reduce or improve the care of hospitalized older adults by reducing or increasing orders for geriatric consults, reducing orders for harmful anticholinergic medicines, and reducing the use of restraints and catheters as these hospital-based complications. So that was the goal. The mechanism through which we were trying to improve the care of those hospitalized older adults with cognitive impairment were through these ingrained alert systems that were built into the medical record system. And here's an example of one of the computerized decision support for promethazine. So this is the interruptive alert that was shown to providers when trying to order a medicine, in this case, the example medicine is promethazine. So in the hospital setting, when a provider attempted to order promethazine, this is the window that showed up. Now, as you all have probably, as many of you has experienced in the past, and maybe you all likely know, there are a number of alert mechanisms that have existed in medical record systems for a long time. This medical record system was called the Gopher system, which is actually initiated or implemented into the routine care of, at least in the hospital environment, in the early 1970s in Indianapolis. And it was generated by the Regan Street Institute, one of the first medical record systems in the world. So when we ran this study in starting in 2005, this was the capability that we had. So this is the infrastructure that we had to build these medical record system interventions. And as you can tell, if there are any human factors engineers in the audience, you might look at this and say, that's not intuitive. That design could be significantly improved, and it could be a significant reason why providers were very adept at learning how to get out of these as quickly as possible, so they didn't interrupt their flow of care. But nonetheless, this is the example. This was the infrastructure that we had to work with in our first attempt at deprescribing high-risk medicines in hospitalized older adults. I'm going to jump ahead to a few quick comments about what did we find out of this study. Now that you've seen the intervention, this is the list of the outcomes that we're attempting to improve, and you can see the proportion of the population. I'm going to skip your attention or focus your attention down to the bottom here, where while we had about 22% of the population who were ordered an anticholinergic medicine, you can see the number who had an anticholinergic discontinuation order. So overall, it's a relatively low across the population, across all who were enrolled, but among those who had an eligible order, we actually saw almost half of those with an anticholinergic order in the intervention group had a discontinuation order, while just over 30% had a discontinuation order for the usual care. So we saw a minor increase in the number of discontinuation orders that may have been caused by the intervention. Now, we don't know if that was caused by a direct result of deprescribing through the computerized decision support, or whether it was influenced by a slightly higher rate of ACE consult or consult-specific referrals, where discontinuing those medicines was also could have also been influenced. But nonetheless, it was a modest. Kind of a modest increase in discontinuation of high-risk medicines in older adults. But still, over half of the anticholinergics prescribed in the acute care setting did not have a discontinuation order. Now, we didn't influence any delirium outcomes, and one of the unintended findings, was that by screening for cognitive impairment and communicating with providers that patients in the intervention group had cognitive impairment or were delirious, we actually saw that there were a higher proportion who had orders for haloperidol during a hospital stay. So one of the unintended consequences was using a high-risk medicine, an antipsychotic, among a cognitively impaired population in the hospital. And so that represents one of the other potential risks of a computerized program alerting to the presence of cognitive impairment. In general, we were not enthusiastic about our deprescribing performance here, although we weren't powered to detect differences in any of those subcategories or individual outcomes. As we reflected on the lessons learned from each of these studies I'm going to share them in the context of kind of the deprescribing audience on the left hand here, and on the right hand we'll have lessons learned or findings or interpretations for the delirium, those interested in delirium research. But what we found in general was kind of a low rate of deprescribing in general, or low rate of medication use, and thus low rate of deprescribing in the study. We had low rates of provider engagement with alerts, as we've talked about in that system. It was known as the F8 syndrome, but it's not specific to that system. And we know that engagement of provider with medication alerts is quite variable, and oftentimes a reason that some of the alerting mechanisms aren't successful in intending to create the behavior that we'd like. And the last lesson learned is that the design was not user friendly. It's very easy, and you think about the flow of care in the acute care environment. When decisions at this point in the process, decisions are oftentimes already made. The last thing that an order enterer wants to do is go back and revisit those decisions. And so that could introduce a reason why those recommendations are poorly incorporated. From a delirium perspective, in this study, we were unable to really determine the impact of deprescribing alerts on delirium outcomes because we didn't significantly influence much of the harms that were occurring, and the medication-specific harms were fairly low in general. And so we weren't powered or didn't have a sample size to look at subgroup-specific outcomes. And the other thing to think about is that while we had no influence on pre-hospital use of deliriogenic medications, and that's going to come into play a little bit more in subsequent studies. But the point at which we found these people, or we didn't have the ability to test delirium incidence, we didn't have any influence on pre-hospital medications. So I think that represents an opportunity for future work. So overall, we kind of saw this study as a failure, where we didn't influence the outcomes that we were looking for. The process measures were mildly to modestly changed, but we still value that work, right? So failure is important to us in our research group, and failure. A lot of people who have been successful have failed in the past too. You'll see a picture here of Bill Gates. And Bill Gates' first company was called Trafo Data, which was a failure. But as we all know, he went on to create other companies successfully, and is a billionaire because of it. You may or may not know this particular character is James Dyson. James Dyson failed 5,126 times at trying to create a prototype for creating a vacuum, and is now worth an estimated $4.5 billion. You might recognize this person as well, who was fired from her first job as an actor in Baltimore and went on to host one of the highest ranking TV shows in history, and is a self-made billionaire. So we embrace failure if we can fail successfully, and that's what we attempted to do as we roll into the next study I'm going to share with you. I'll just briefly comment as we transition to that next study that we did do a little bit of a qualitative evaluation with providers after that first ECHAMP study, and asking how would you improve the intervention so that we could improve its impact. And the message that we heard was that, well, if we ignore the alerts, then what we'd like for you to do is give us, and these are medication-based recommendations, then we'd like for you to give us access to a pharmacist when we ignore those alerts, where we can have more of a dialogue and make a more educated decision, perhaps, about whether we should stop those dangerous medications. So in our next attempt at improving delirium outcomes in the hospital environment, ooh, that went quick, we built that into the intervention. So in our next study, we aim to determine the impact of, again, a multi-component pharmacologic intervention on delirium outcomes among critically ill adults who were hospitalized in the intensive care unit. And so for this model, the mechanism through which we tried to build the intervention was to address the neurotransmitter pathways that we thought at the time were leading to delirium in the ICU. And so that includes a deficiency of acetylcholine, that includes, as well as excessive amounts of dopamine and GABAergic activity at, oops, let's go this way. So that intervention is aiming, that pharmacologic intervention aims to address neurotransmitter imbalances of the cholinergic, dopaminergic, and GABAergic systems, and that brought us to the PharmD intervention. So ultimately, that intervention included that pharmacologic signature for delirium treatment among those who screened positive for delirium in the ICU was to provide a low dose of haloperidol, to deprescribe anticholinergics among those who were using anticholinergic medicines, and also deprescribe benzodiazepines. So the mechanism through which we delivered this was, again, a largely pharmacist-based intervention, which initiated the use of haloperidol for up to 7 days. Anticholinergic reduction was employed we used the EMR alerts because they had already been built. And so we could turn those on. But where the EMR alerts failed, or the computerized decision support failed, we had a pharmacist offer surveillance 7 days a week for those orders throughout the hospital stay. So among those intervention patients where anticholinergics were not discontinued, the pharmacist would communicate either by phone or through pager at the time about those orders and question the appropriateness of those. We did not have EMR alerts built for the benzodiazepine reduction, but that was intervened through pharmacist surveillance as well and through direct communication either by phone or by pager. Unfortunately, I'm going to draw your attention to, and in the interest of time, the process measures for which medication exposure was measured in this study. So you can see up above, benzodiazepines were, between the intervention and usual care groups, we had a slight reduction in both the number exposed and the median daily dose of benzodiazepine that may have been a result of the intervention. From an anticholinergic perspective, though, we didn't significantly change the number, the proportion exposed. And so again, we were left somewhat disappointed with the performance of, again, the multi-component intervention at reducing exposure to anticholinergic medicines. So some of our lessons learned from this study, while we didn't change from a deprescribing perspective, our computerized alerts didn't significantly change the rates at which anticholinergics specifically were initiated, but they may have reduced the duration at which someone may have been exposed. And that, I think, is attributed to largely the supplementation of the CDS with the pharmacist introduction. So while providers may have ignored the computerized decision alert so that patients may have gotten that initial exposure, the intervention may have reduced repeated dosing of those medications a bit better than what usual care. Now, I'll remind you that usual care at our location already includes pharmacists incorporated into the team. And so usual care at the time was of high quality. And a different result may have occurred if this study were conducted at a different location where pharmacists aren't already a part of the team. Again, we saw continued poor provider interaction with alerts. And again, I'll just reiterate that similar to the first study, we used the same computerized decision support design, which really lacks best practices in deprescribing that has been published in more recent years. From a delirium perspective, again, these are the participants in this study were those with delirium required for participation. And so because we didn't significantly influence medication, anticholinergic and benzodiazepine medication use, we're really unable to determine whether deprescribing alone can influence a delirium clinical outcome among a group who's already delirious. And you'll see the third point at the bottom, because this was a population with incident delirium already, we were only really limited at testing the impact of acute exposure. And so there could be an opportunity for delirium susceptibility from pre-delirium medication exposure. So those are potential opportunities that we'll discuss in a few minutes. So I can see some numbers increasing in the chat and in the Q&A. I feel free to add some comments, add some questions. We're happy to address those. I can't see those at the moment, so I won't address those as we go through the slides. But I'm aiming to leave some time before we finish. And to do that, I'm going to move ahead a little bit more quickly into our next objective, which is to identify opportunities for deprescribing research that can add value to delirium care. I'm going to do that by describing, by orienting you to a figure where we kind of describe some different phases of where medication exposure could be of particular interest as we talk about deprescribing and delirium. So if you look at our kind of time plot with the dotted lines indicating some kind of a variable amount of time, and we think about what we might describe as a more common delirium episode that oftentimes occurs either at or shortly after the time of hospital admission. And so I'll describe that maybe delirium time course or journey map first, and then think about the different phases of medication use that might be of interest. So if we think about admission occurring at the beginning of the solid black line, and then I know delirium, oftentimes patients present with delirium, but let's think about that time course for the purposes of illustration. I want to think about the time course of delirium onset while presenting to the hospital environment without delirium. So if we think about a participants or patients that present to the hospital setting at admission, delirium develops, ideally delirium resolves, and then discharge ensues. Best case scenario, discharge alive ensues. There are some meaningful phases of medication exposure, I think, that still need to be understood as we build the case for deprescribing interventions. And the first that I'll highlight is that pre-hospital period. And right now, a lot of times we think about medication exposure as a precipitating factor on top of someone with predisposing risk factors. But I'd like us to think about, or shift and think about, what susceptibilities or vulnerabilities could medication exposure in that pre-hospital phase be causing. And I know that there's a number, there are a number of studies that have been published attempting to address this. But my read of those studies is that our ability to capture pre-hospital exposure, maybe 3 months, 6 months, maybe even 12 months, or even longer, in that pre-hospital or pre-delirium phase is poorly characterized. I think that represents an opportunity to maybe shift from thinking about medicine in that pre-delirium phase from being maybe not just a precipitating, but a predisposing factor, in that medication is potentially influencing the central environment to be more of a predisposing factor than just a precipitating factor. So let's also talk about that medication, how that medication exposure may either change from the point of admission to the delirium onset, or that time between admission and delirium resolution. So medication can potentially influence whether it has been initiated as a and could be a precipitating factor, but between that initiation, between the time of admission and delirium onset, it could certainly influence those delirium outcomes. But it could be also influencing those delirium outcomes if it were stopped between admission and delirium onset. So deprescribing a medication that had been used in that pre-hospital period is certainly an approach to medication use that's relevant in building the case for deprescribing and delirium outcomes. And the last phase that the delirium world is really well versed in is what happens after delirium resolution, but in that post-discharge phase, where we know in some people cognition can acutely decline, significantly decline, and we have to thank Sharon and the work from the SAGES group in helping to describe that, as well as Pratik and the group at Vanderbilt, who helped us understand that even after discharge, after delirium resolution, there could be a significant sustained decline in cognition that is of particular importance. And one of the things that we've learned out of the clinical trials attempting to treat delirium in the hospital setting is that some of those medicines that people are getting or receiving, and with the intent to treat delirium symptoms, about 25% of those can continue at discharge and beyond. And so we really need to understand what the influence, or if there's an influence or relationship between those medicines, new medicines prescribed in the hospital setting, could be influencing those post-discharge outcomes. And so there are a couple phases there. The next couple slides, I just reiterate these points in a slightly different way, and really declaring these pre-hospital use of medicines as a potentially precipitating versus predisposing factor, this in-hospital pre-delirium phase, where we want to pay attention to initiation of medicines, continuation of medicines, and discontinuation of medicines, as they may all potentially influence delirium outcomes. There's a lot of ways to dissect medication exposure in that pre, peri, and post-delirium phases that may contribute to meaningful outcomes. And so in the next slide, I kind of reiterate the same point, but kind of phrasing that relationship that we'd like to study translating them or carrying them forward to how they might be phrased in a deprescribing sense, in that can pre-hospital deprescribing reduce risk of delirium? Does deprescribing in the acute environment result in harm or benefit? And does deprescribing at discharge or following a delirious episode, can that influence delirium recovery or long-term cognitive impairment? And I reference at the bottom here some of the work that Hussein Khalil, one of my graduate students, is doing in trying to understand and characterize the ways that, particularly related to this first bullet point, of whether the ways in which the existing literature characterizes pre-hospital medication use, and identifying opportunities that we all can pursue to try to lay out potential opportunities for deprescribing in that pre-hospital phase. So I want to chase those thoughts with some of the justification for looking at medications in the pre-hospital phase. So we know that there are a couple mechanisms through which medications can influence delirium. One is potentially, and so one of the exciting areas in delirium research lately has been in trying to better understand the blood-brain barrier. We understand the blood-brain barrier intends to protect the brain, but the blood-brain barrier can be compromised by age, by comorbidity. And what we're beginning to understand is the blood-brain barrier may be different in people who have certain risk factors for cognitive impairment, as well as both dementia and delirium, by being carriers of ApoE4. And the blood-brain barrier may look different in different people. And so whether the blood-brain barrier is doing its job by keeping certain medications out of the CNS, it becomes another question that we need to ask. And so all those qualifying medications through their likelihood of penetrating the blood-brain barrier becomes less important, and we need to expand the number of medications through which we are concerned about as far as causing delirium. And so one of the examples recently is one of the new discoveries might be that angiotensin receptor blockers may influence the stability of the blood-brain barrier, but the timeline at which it could do that is not well understood. And so there's a potential mechanism not only for medications to change the architecture of the brain environment that we need to be aware of as a potential mechanism through which medications can influence delirium outcomes, but we could also consider medications that might protect the brain, in that one of the mechanisms through which ARBs could prevent delirium or adverse cognitive outcomes might be to stabilize that blood-brain barrier. And so that's worth understanding in much more detail as that hypothesis develops. Again, I'll reinforce that these are hypotheses only at this point, but there is some literature pointing in that direction that needs to be better understood. The other mechanisms that's a little bit more direct and that people are quite commonly familiar with are the direct impact of medications on neurotransmitter systems. And so these are relationships that are more consistently explained. One being that our group has contributed to, and that's the relationship between anticholinergic medicines and dementia, as well as anticholinergic medicines and mild cognitive impairments, or the transition from normal cognition into a worse state known as MCI, that have been well described in prior work. But that direct impact of medication on cognition or on neurotransmitter systems can still be explored directly, and that offers some justification for that pre-hospital exposure. And understanding what happens to those medicines in that transition period from chronic use before the hospital setting to acute use, or acute use during that hospital setting, and how do those changes maybe influence the delirium onset or duration. And so I want to close that line of thinking with highlighting some of the work that Louise Rose recently led in creating a core outcome set for delirium clinical trials. And this is important work. And the reason that I highlight this is a lot of work is focused on delirium incidence, and a lot of the existing literature is focused on delirium incidence. And while that is particularly important, the outcomes, the meaningful delirium outcomes, including severity and duration, as well as long-term cognition, are also of particular importance. If, like in our studies, if we find, and some of the work that's been done trying to identify antipsychotics as potential treatments for those who experience delirium, if we aren't able to influence delirium incidence or delirium duration, severity is also important. So these other these other outcomes are also of significant importance, and I think understudied as it relates to the role of medications as either risk factors or treatments for delirium. And so there's always room to contribute additional knowledge on not just incidence, but also severity and duration, as well as post-delirium outcomes like long-term cognition, and as well as emotional distress and health-related quality of life. Those are certainly impactful to patients and caregivers. And I want to excuse me, I want to credit Louise in this work for contributing these core outcome set suggestions for delirium research. So I'm gonna transition then and go back to some comments, kind of addressing our ability to improve from our prior, how do I want to describe it, modestly or unsuccessful deprescribing attempts in these archaic medical record systems. And share with you some of the ways in which we've improved our design and development of deprescribing interventions from those systems that we previously used. And again, recognizing that we're not really recognizing that work as failure, but just negative results, meaning we tried something, it didn't work. Let's circle the wagons, but realizing that we need to try something new and try something different. And in the next couple minutes, I want to share with you some thoughts on how we were able to do that, but in a different environment, in a different care environment, and with support from AHRQ. And part of what AHRQ required as we moved ahead and kind of revising our deprescribing interventions going forward was that we take a different approach to solving the problem of trying to reduce or improve brain health by reducing use of high-risk medicines. Part of the context was that we know that we had tried this before in different care environments with different types of interventions, but we shifted towards more outpatient focuses because we'd seen that a lot of the use of high-risk medicines in the healthcare system comes from the outpatient population. And our internal analysis of medication volume or prescription volume over time over the course of nearly 10 years that you can see here was fairly flat. So we hadn't, in anything we'd done to date, we hadn't influenced or reduced the amount of high-risk medication use to that point. So we introduced a new way of thinking about a new process for trying to solve the problem of improving our ways to deprescribe high-risk medicines. And one of those steps was to ideate, or to understand. The first step was to understand the problem more deeply. And so we did that. We understood that there are many stakeholders involved in the process of prescribing and using high-risk medicines. And at the center of those are the patient and the provider. And so we ideated a number of different approaches that we could take, not just on those two stakeholders, but also the pharmacist, the pharmacy system, the healthcare system, policy, as well as the patient and the patient social network. But unfortunately, time and money restricted the number of resources that we could pursue. So we restricted those. But as we built these new interventions and designed them for the outpatient environment, we did this at about the same time that the deprescribing world was starting to shift its focus on seeing prescribing and thus deprescribing as behavior change, or kind of maybe influenced by certain behavioral theories. And so we began to define deprescribing and or prescribing as a behavior that is infrequent, complicated, lacks immediate feedback, and has delayed benefits. And as such, we began to think that maybe deprescribing could be influenced by behavioral economics principles. And so we began to learn about behavioral economics and how it could influence deprescribing in that sense, and kind of overlaid lessons that we'd learned from the UK nudge units that were originally developed. And so we began to build in, as elements of our deprescribing interventions, features like salience, like priming, like setting defaults, creating incentives. And these different features were employed at anywhere from patient and provider to healthcare system leadership, and helping them understand what the impact of potential deprescribing interventions could be. As we carried these forward, and those interventions kind of helped us communicate with healthcare leadership, more so some of the loss aversion or incentive-based components. What we built into our provider and patient-specific features were alerting systems, priming systems. And one example you can see here that we built within Epic, which is our healthcare system transitioned then to Epic. And so we built these alerting mechanisms with a largely different design than what you saw in the first few slides in our first studies. And these alerts had a couple different unique features. One, that they identified risks of potential anticholinergic use, and anticholinergics being our target. They identified indication-specific alternatives. They offered auto-population of titrations to get to those alternatives. And you can see some of those alerts where providers could select the particular indication, the particular medicine someone is using in the indication. And after selecting those, an auto-populated titration schedule would come over to a safer alternative. We also, from the patient perspective, we developed staff and MA focused. We utilized outpatient staff, medical assistants to identify or introduce patients into a patient-facing form of the intervention, which includes videos as well as an app that was included on the tablet that was used to deliver the videos in the outpatient environment. And so the intent was to intervene on both provider and patient at the same time, and right before they're in the room together. And so we created these tools and turned them on to a cluster randomized trial among 10 primary care clinics within Eskenazi Health, and we ran this from April 2019 through just before the COVID interruption in March of 2020. And we used as a comparison the 1 year prior, between 2018 and 2019. And so disappointingly, I have to tell you that as I look at my time, I'm going to go quickly here. Disappointing, this did not have the impact that we hoped it would. And again, part of the reasons were that there was a poor alerting interaction between providers and alerts. So we saw that only 15% of the alerts were opened, 1.2% of all alerts resulted in a change, and a measure that some of you might be familiar with, the number needed to remind, was 86, meaning that 86 alerts have to fire before the behavior that is intended is executed. And so that's something that we need to improve upon still, despite the multi-component nature of our deprescribing intervention. In the last couple slides, I'm just going to highlight some of the work out of Ohio State that also uses Epic, and you can see here the range of performance of Epic decision support alerting mechanisms, anywhere from 91% to 1%. And so there's a range of how successful these alerts can be, and that tells us there may be a potential opportunity for continuing to improve upon EMR-based alerting mechanisms. So I'm going to close with the summary. I'll just hide this slide. I'll show this slide quickly. We can come back to it, but I want to close with reiterating some of the opportunities that we have to use deprescribing opportunities to improve delirium outcomes. I think there's a great deal of opportunity. I invite you to join us in that space and collaborate in that space as well. I know there are a lot of resources that US Deprescribing Network offers, that NIDUS offers, that we encourage your engagement in. I was going to tease you with a couple things going on within our lab, but we'll have to save that for a future webinar that I'd be happy to talk more about. And I lastly want to credit our multidisciplinary research team that has been that's executed the work that I presented today, and appreciate their support of this. So I'm going to pause here and migrate over to some questions and dialogue.
Thanks, Noll. Great presentation. Really cool to see your evolution from a DOS system to behavioral economics. So for everybody listening, please type your questions into Q&A or chat. We have a few minutes, and so let me read a few to you, Noll. So one is a question about those who are doing work with secondary data and suggestions on addressing limitations regarding data quality for delirium, particularly noted post-acute care settings.
Yeah, I think that's a significant challenge, right? So we recognize that there's a significant underreporting of potential delirium in some of those data sets coming out of those groups. I think it will improve over time, but secondary data analyses with long-term care data sets, we're going to be challenged to interpret those results until we are disincentivized, until we're incentivized to provide quality care and quality recognition of delirium. And I think there's a concern that some of that is disincentivized. So I don't know that off the top of my head I have the right response or the right solution to working with those data sets where delirium is under-identified. But I think there can be lessons valued. I think that's a significant limitation to working with a lot of those. But there are also increasing opportunities to recognize, to using not just administrative codes, but also a number of different elements in recognizing delirium, where we're not just relying on a diagnosis code, but we're using different elements of medical record systems as well as administrative records and claims data, where we can significantly improve the identification of delirium. And Sharon, I see you shaking your head, and I'd invite your comment to that as well.
Yes, I do think that we have to work on natural language processing ways to recognize delirium from medical records. I think there are ways that people are using to pull in ICD-10 codes along with medication codes, unfortunately still antipsychotics, as well as restraints. But these are picking up just a very small proportion of delirium and mainly agitated delirium. So we have a long way to go yet. But I agree, it's very important.
There's a question that came in, Noll, about the role of pharmacogenomics to determine or predict people's response to medication, perhaps to psychotropics. Can you make a comment on that?
My comment will be brief. I think that's an opportunity because of the heterogeneity of delirium etiologies. I think there are a lot of times when we think of pharmacogenomics, we think of the way that pharmacogenomics can influence pharmacokinetics. But there are a lot of ways to use pharmacogenomics potentially in delirium research, which include dopamine transporter systems. And I think that's potentially an opportunity. With that said, we also need to recognize the potential benefits of any medicine in delirium prevention and delirium treatment, but we also need to think about how those unique populations could experience risk as well.
Another question was, in your interventions, or either study interventions or others, do you recommend non-medication alternatives as part of your intervention, such as cognitive behavioral therapy?
Yeah, absolutely. That's relevant for both acute care studies as well as outpatient studies. So Sharon knows this as well. Anything that we want to offer to somebody as far as changing a medicine to reduce risks of medicines, even in the acute care environment, we can offer them non-pharm alternatives. In the outpatient environment, yes, the intent is that we support engagement with those non-pharmacologic options, and in some cases, non-pharmacologic options can be the same as, if not more, more successful at managing a symptom than the medication itself, but we have to adhere to them. And so one of the challenges in at least outpatient deprescribing is encouraging and adhering to those non-pharmacologic opportunities. And that is one of the challenges, but in many deprescribing studies, there's an assumption that can almost be made that those non-pharmacologic options have already been maximized. But I think we all know that that's oftentimes not the case. But the ideal intervention does both, right? So it supports adherence to non-pharmacologic intervention as well as prioritizes safe medication use.
Great. Well, I think that's all the time we have for questions. Thank you again to all our presenters and to all our attendees for coming on to today's webinar. There was a question about the recording, which will be available on the US Deprescribing Research Network website within a week or so. And please look in your emails for a short evaluation survey and respond to that. Thank you again. And our next webinar will be probably in March sometime, and look for announcements for that. Have a great rest of your day, everybody.
Thank you, Noll, for great presentation, and thank you, USDeN.
Thank you all. Great to see you.